ممتاز. يلا ابتدي.
Right, today we are going to talk about a case of CRT implantation, and we had some issues during implantation. We are going to talk about troubleshooting. Case is a 65-year-old male married with 4 offsprings, hypertensive on ACE inhibitor, diabetic type 2 on insulin therapy, ischemic heart disease, post-CABG 2013 on anti-ischemic treatment. He was presented to emergency department with syncopal attack not related to exertion or emotional stress. Vital signs were okay, local exams were nothing significant, lab results were within normal, cardiac enzymes, PNB and D-dimer. MRI was free from recent stroke or intracranial hemorrhage. This was the ECG findings during presentation, right bundle branch block and first degree heart block. Actually, axis deviation was almost right axis deviation by calculation of lead 1, 2, 3 and AVF. Findings show dilated LV internal dimensions with impaired systolic function. Ejection fraction was around 33%. Diastolic dysfunction grade 1. Resting segmental wall motion, akinesia, inferior and posterior wall. Rest of segments were hypokinetic. Dilated left atrium, moderate mitral regurg, mild tricuspid regurg. We did a multi-slice CT for this patient as he is a CABG patient and showed patent lima and 2 saphenous venous grafts. We also performed a carotid duplex for this patient to exclude any carotid disease, and there was nothing significant about his cranial and carotid system, only atherosclerosis. We did Holter, and the Holter showed multiple findings. First is a second degree heart block, Poppets type 1, prolonged prolongation for PR interval, and then dropped beat. Holter also showed with multiple couplets. According to ECG recommendation for fascicular block with ejection fraction below 35, CRT-D is recommended, so we decided to implant CRT-D. Actually, we had 2 problems during implantation of CRT. The cannulation of coronary ostium, we had difficulty during cannulation of coronary ostium. Another problem was getting the vein, the lateral vein. Multiple trials, and the wire was withdrawn multiple times. This was the final result, and I will explain simple steps of LV lead implant steps. Was to cannulate the coronary sinus, perform coronary sinus venografts, select target vein and LV lead, place the LV lead and take electrical measurements and remove delivery system tools. Those are the simple LV lead implant steps. And the key points in cannulating coronary sinus is to place LV lead first or RV lead first. Most interventionists prefer to place the LV lead first. Either way, it might save time and money. But the only cons is there is no backup pacing. For RV lead placed first, there is backup pacing, but it may get in the way of the LV sheaths. Actually, the only cause for, there are multiple causes for coronary sinus cannulation, valves obstructing the catheter or advancement, variable coronary sinus ostium location, dilated right atrium, severe kinking of the vein, and small vessel size of coronary sinus. First valves that might obstruct the cannulation of coronary sinus is the Zebesian valve. It's crescent shaped, semilunar shaped, or fenestrated. This is the shape of the Debesian valve obstructing the coronary sinus inflow. Another valve is the Busen's valve, and it is located as a transition from the coronary sinus to the great cardiac vein. It might impede the catheter advancement at the coronary sinus. We had difficulty in cannulation the lateral vein, so we picked for a sub-selector. There are a lot of types and shapes for sub-selectors. They named the attained leads. You can pick whatever the shape you want according to the ostium of the LV lead and the tortuosity. You might use another techniques like pushing the wire as much inside the vein, or you can use double wire for extra support. You can use a stiffer wire or harder wire to improve to reduce the tortuosity and provide extra support. Last option you have is you can do coronary sinus side branch stenting, but it may cause injury to the lead insulation. This is the last option you have for extra support. Last, we managed to implant the CRT. We did our optimization. The home message is revising patient data, characteristics, and risk factors. Important before decision to implant CRT. Always be ready with full tool package and assisting device before starting CRT implantation procedure. There are a lot of useful courses and online data for learning and upgrading knowledge for free as Medtronic Academy. I think a lot of colleagues know that Medtronic has free online learning tool called Medtronic Academy. Actually, I revised it before introducing today this presentation, and this is a screenshot for a course I have taken. They have a lot of courses. You can register for free. They have a lot of courses. You can take it for free. A lot of presentations and PDF and courses, and all for free online. Thank you. Hello.
السلام عليكم.